and she's a unit head of cornea and also eye banking, refractive surgery, cataract surgery, and strabismus and neuro-ophthalmology. So that's a bag full of specialties for her. But actually, she was trained that way. You know, she did her thesis in glaucoma with the same mentors that I had. So all through my thesis, I used to get to hear about Radhika and her wonderful thesis on acetazolamide drops, I believe, in glaucoma, and how good she is and all that. And then she did a senior residency in retina before she moved to UK for a double fellowship. She came back and joined Epicenter, worked in strabismus neuro-ophthalmology and cornea. So she's a pan-ophthalmologist and excels in all specialties of ophthalmology. That's her USP. And absolutely so, because she has rewritten the book of Parsons, the Parsons has been rewritten by Dr. Radhika Tandon and Ramanjit Sihota, both of who are pan-ophthalmologists. They know everything about ophthalmology at any given point in time. So it's so lucky to have her, and over to you, Dr. Radhika, to speak on corneal stromal, descendant membrane, and endothelial dystrophy.
Thank you so much, Dr. Santosh, for that very kind introduction. It's always an honor and pleasure to take part in any academic program organized by Santosh, because he's very meticulous and himself an excellent academician and a wonderful person. So this lecture is on corneal dystrophies. I've just clubbed it a little bit with degenerations, though I do know that you've already had a lecture before, simply to give you a little bit of a recap of what you heard in Shreyas's lecture. So when we're talking about corneal dystrophies, one second, I have to advance the slide. I'm having difficulty advancing the slide, strangely enough. Just give me a second.
Sunilji?
Yeah, it's gone ahead. So one mustn't forget that though when one looks at the chart, it seems that, you know, what's the big deal? It's very easy to differentiate a dystrophy from a degeneration. But there are certain exceptions to the rule, and I will highlight later on. So sometimes it can actually be a little difficult. So generally dystrophies are bilateral, they're heritable, they have a central location, and largely they do involve a single corneal layer. Later on in the lecture, I will illustrate how that's not entirely true, but largely predominantly remember that there will be one corneal layer which is predominantly affected, and it will have a different pathogenesis. Generally, degenerations are unilateral, but there again, you'll find throughout your ophthalmic clinical work that many times they will be bilateral. They are non-familial. They could be peripheral or central. They may not affect any specific layer characteristically. And their pathogenesis is usually a result of degenerative processes as a result of age or inflammation, some systemic disease, some deposition of material, or secondary to other conditions which are leading to vascularization or thinning. So to give you a few examples, in a degeneration, there's a deterioration or a change to a less functionally active form of the tissue. So you have arcus senalis, you may have Vaux-Limbel girdle. This is an example of a Coates-White ring and crocodile shagreen, and so on. There could be Hassel-Henle bodies, senile furrow degeneration like you have over here, and there could also be Tyrrhen's marginal degeneration. In fact, Tyrrhen's marginal degeneration and pellucid marginal degeneration are very important because they can often be considered in the differential diagnosis for the ectatic corneal diseases as well. Now, coming to the corneal dystrophies, if you define corneal dystrophies, it is a heterogeneous group of corneal diseases. Now, why have they been put together? Because as I explained in the beginning, they have certain common features. They are inherited, they are bilateral, they are generally symmetric, but sometimes they can be asymmetric, and they will not be associated with any systemic disorder. There are exceptions. Sometimes you can have, though it's supposed to have a hereditary pattern, but many times one will get isolated cases. And this you can understand because there may be a fresh mutation in a particular individual or a particular generation. So therefore, though it has a hereditary tendency, in a particular family, you may have an isolated case. And they're largely bilaterally asymmetric, but you can have asymmetric manifestations as well. The other point I had mentioned is that they are usually not related to any systemic factors, but now as the evolution of the diseases has improved, greater knowledge of pathogenesis, and also greater armamentarium available to us in terms of testing and higher biochemical analysis and so on. So technically, macular corneal dystrophy, the serum keratin sulfate does correlate with certain immunophenotypes. So if you say that there may not be any systemic manifestation in terms of any systemic features or any systemic problems, but if you truly speaking see there is a kind of a systemic involvement. And some cases of lattice corneal dystrophy may actually have systemic clinical manifestations as well. And over the years, it was felt that a little bit more organization is required, because as I'm explaining all these exceptions, so similarly, from across the world, many corneal specialists did realize that there were certain definitions or certain characteristic features that were known, but there were a lot of atypical cases and sort of ones which were not falling typically anywhere. So therefore, there was a move to get some kind of a standardization or a uniformity in the terminology used, so that one could be on the same page and one would be able to compare results from different countries, whether it was research studies or simply having a good idea about the clinical manifestations. So there was the move to develop the International Cornea Classification of the corneal dystrophies, known as the IC3D classification, which is published in the journal Cornea. It was initially proposed in 2008 and then updated in 2014. Now, traditionally, as is natural, one would classify the dystrophies based on what one found clinically. And apart from the history, the basic thing that we ophthalmologists use for classifying or for assessing a patient is our clinical examination with a slit lamp. So there was a traditional anatomical, a physical variation that you found, which was used to classify as, say, epithelial dystrophies, stromal dystrophies, and the endothelial dystrophies. However, as more and more genetic information came in and as more and more studies or greater interest was developed, when people actually looked at the the genotype, then the clinical manifestation in terms of the phenotype, and actually looked at the variations, they found that there were a lot of gray areas. So therefore, it was felt that a revised classification was needed, as technically, if you go by histopathology or even with clinical assessment, most dystrophies do not confine to one anatomical layer. And similarly, there could be different categories and identification of genes. And here we must give a lot of credit to the beauty of clinical medicine and the perspicacity and the diligence of some ophthalmologists who meticulously see their patients, keep the record, and analyze. It's not that they just see something and they forget about it. They actually analyze, they try to assess. So several series and several case reports as well as analysis of families have shown up many interesting features, which I'm going to then illustrate in the next few slides. So the updated IC3D classification has now understood that the traditional anatomical level of the corneal dystrophy has its limitations. To give you a few examples, the Rees-Buckler corneal dystrophy, for example, was traditionally felt to be largely subepithelial, but it does affect more than the subepithelial layer. And the macular corneal dystrophy, which was considered as largely a stromal dystrophy, it does have an endothelial involvement as well. The other thing is that earlier it was quite confusing with so many dystrophies being classified as Bowman's layer dystrophies, Descemet membrane dystrophies, when actually it was found that they were not distinct types if you take all the criteria that are now considered important to label something as a corneal dystrophy. So these were then removed from the classification. And then they removed the specific table of the specific genes, and they reclassified CHED type 1 as PPCD, and they also included 3 variants of the epithelial recurrent erosion dystrophy. So here I'd like to explain that when the IC3D classification was revised, the anatomical association still remains, because as ophthalmologists, it's easier for us to understand, and also from a clinical perspective, we need to know which is the layer which is predominantly involved. But they have recognized that there can be an overlap. So therefore, we have largely epithelial and subepithelial dystrophies. It's unlikely that one of these is going to actually affect the endothelium. So it will be the epithelial and the subepithelial layer, and then epithelial and stromal. So they will involve the stroma to a lesser or a greater extent, depending on the particular type. And so this is one thing to understand, that it is no longer restricted to just epithelial or just stromal. Secondly, as I mentioned, the Bowman's layer dystrophies have been removed, and they have been just combined with the layer that they are predominantly affected with. And then the categorization of the dystrophy is also being done depending upon how characteristic the features are. And I will show you in a table what is the difference between a C1 category, C2 category, and C3 category, and so on. So this is the whole chart of the various dystrophies, and the superficial dystrophies will be the epithelial and subepithelial. And what we consider as stromal, they may have some element of epithelial involvement. So here we have the Rees-Buckler, Thiel-Behnke, lattice, macular dystrophies. And then we have the stromal dystrophies, which will predominantly affect the stromal layer. So here you can see macular corneal dystrophy is predominantly a stromal dystrophy. However, as we have recognized earlier, that you will have some involvement of the endothelial as well, but it is largely affecting the stroma, so it is classified as a stromal dystrophy. And you will see sometimes patients of macular corneal dystrophy who will have manifestations of granular-like deposits which are more anterior and will produce an irregularity of the surface epithelium as well. And with the clinical examples, I will show you how to differentiate. And so this is the list of the stromal dystrophies, and then we have the endothelial dystrophies, the most important being Fuchs endothelial corneal dystrophy and congenital hereditary endothelial dystrophy. So this is what I meant. Category 1, one would consider as, if you consider as a hierarchy, it would be taken as the highest level in terms of how well defined it is, how much we know about it, and how predictable it is. So the category 1 dystrophies, the genetic locus is known, the gene is known, it's well defined, the features of the clinical aspects are well defined. So the example of this is CHED2. Category 2 dystrophies, where the genetic locus is known, the specific gene is not known, the features were well defined, and has been put as CHED1. And then category 3, where these are just examples, and as you see in the table which I mentioned earlier, all of the dystrophies have now been categorized in one of these 1, 2, 3, or 4. Now the category 4, one may argue that if everything is so doubtful, then why put it as a corneal dystrophy at all? That is because it still retains some of the other features. They would be bilateral. There is an inheritable pattern, though you don't know the specific genetic locus. And as we found over the ages, hardly any of this information was known 20, 30 years ago, and we have evolved and know so much more about them. So there is hope that these category 4 dystrophies also will be getting better defined in the future. Now, coming to the epithelial-stromal corneal dystrophies, these are really interesting. They are the TGF-beta1 dystrophies, Rees-Buckler, Thiel-Behnke, lattice, and granular. It's extremely interesting because they all have slightly different phenotype. So they will all have a slightly different appearance when clinically assessed. They all affect the various layers of the cornea, but again, to a greater or lesser extent. So for example, in lattice corneal dystrophies, the lesions will be tending to be more deeper. Largely granular dystrophy in the early stages will be more superficial, but the older the person gets, you will find that the granular deposits will go entirely through the entire depth of the cornea. And Rees-Bucklers and Thiel-Behnke are largely anterior. But if you see the genetics, so this is an example of the similar genotype having a lot of variation in the phenotype. So this is an extremely interesting set of dystrophies. They are known as a TGF-beta1 epithelial-stromal dystrophies. To give you some examples, here we have the granular corneal dystrophy type 1. It is autosomal dominant. The genetic locus is known, the mutation is known, and it comes in category C1. The gene and its effect is known, and what is the product which is deposited, that is also well known. Largely, the onset is in childhood, though it will not be manifesting that much in childhood because the symptoms will not be that obvious. So the course is slowly progressive, and most patients will maintain good vision. But if you happen to see this child on the slit lamp, or if the person belongs to a family where other family members are known, then one would be able to detect it at a very early age. And as you can see, there are these distinct, discrete opacities. They are whitish opacities. And when you see under a slit, you will find that they are largely anterior or mid-stromal, and the intervening cornea looks clear. Also, they're largely central. As I had explained earlier, the paracentral and peripheral lesions tend to be more degenerations. But here again, as the person ages and as the disease progresses, later on you may find that the opacities are scattered all over, and sometimes it can be quite confusing. Now, this is to show you that this is also a granular dystrophy, but there are such variations in the type of granules and the appearance. So these are crumb-like opacities. They are small, discrete, and sharply demarcated. And often they may even have a linear configuration or a linear deposition if you see this. Otherwise, they may be scattered, as you can see in the lower picture. Now, as the, you can see in this case, it's looking a little bit different. You may even mistake it for a crystalline dystrophy because if you look at the edges, they do have little needle-like protrusions. So this is when the genetics helps. This is when comparison with the other family members helps. And you may also find that the nature of the opacities may not be identical among different family members, whereas some families, they will actually be identical. Now, generally early on when these lesions develop, the patients may have symptoms of glare and photophobia. And as the opacity progresses, visual acuity decreases and recurrent erosions may also be seen. And on light microscopy staining, histopathology. Now, histopathological material is not always very easily accessible. It will only be available if the patient undergoes a keratoplasty. And since the vision is not that affected, often such patients will not undergo a keratoplasty earlier on, but later on they will go, may undergo a DALK, and such tissues are very precious. They should always be sent for histopathology. And the multiple stromal deposits would be seen extending from the deep epithelium. And here the histopathology is what may show you that variations may actually show that the deposits may be present as deep as 3 Descemet's layer, though clinically you may not see these deposits. So it shows that at a molecular level or at a cellular level, the deposits are present, but they are not clinically manifesting when you see the patient on a slit lamp. And then if you want to characterize them further, one can do electron microscopy, and you may see these characteristic rod-shaped lesions. And confocal microscopy is actually very interesting and very useful because it gives you in vivo an appearance, which will tell you straight away. Now, these two pictures are not from the same patient. So therefore, you can see how there can be variations. But if you have the confocal microscopy and the histopathology of the same patient, often you will find that the lesions and the deposits, the nature of the deposits, the reflectivity, the shape, the morphology will often be very similar. So confocal microscopy is a very useful tool to document these lesions. Again, it is more of academic interest, or if you want to keep a very meticulous record of the patients. As far as the actual clinical diagnosis or patient care is concerned, confocal microscopy will not make a huge difference. But what would make a difference is the vision assessment as well as the ASOCT to document the depth of the lesion. And even pentacam can be useful because you can do a densitometry and have a quantifiable objective measure to the extent of the corneal haziness. And looking at the granular corneal dystrophy type 2, earlier it was called avelino-dystrophy. Also, when you called a combined granular and lattice dystrophy, because you get overlapping features of both. And here the genetic locus is known. So again, this comes in the category 1. Inheritance is autosomal dominant. The gene is known and the product is also known. So here is an example of lattice dystrophy. As you can see, there are lattice-like lines available. You need to differentiate these from prominent corneal nerves. You should not mistake this for the kind of radial neuritis that you will get in a case of acanthamoeba keratitis, because it's a quiet eye and the nature of the branching is totally different. And you will also find that there are these translucent lines which will be present on a slit examination. They will look very translucent. And a very good method of ascertaining or highlighting these lesions is to do a retro-illumination examination with a dilated pupil and keeping the beam, the illumination and the viewing beam aligned so that you get the red reflex from the fundus and you can clearly view the lesions, as can be seen in this picture below. You may get stellate shapes, snowflake, icicle-like opacities as well. And it is the dashed lines and the translucency which is very characteristic. So at a particular angle, the lesions will look very white. They will be reflecting the light, whereas at a different angle, or sometimes it will maybe adjacent, the adjacent by indirect focal illumination, you will find some of them are very translucent. And that helps to differentiate them and identify it as the lattice dystrophy. This is lattice dystrophy type 1. Sometimes the features can be extremely subtle. And the other important thing is, in a country like India, where you often have chronic inflammation from trachoma or dry eye and ocular surface disease, one can even have secondary amyloid deposition as a secondary change in the cornea. And that can give you what could appear like a lattice dystrophy. So that would be an example where it is actually a degeneration, where the lesions may be central, and it may even be bilateral, and it can be confusing. And these were the former alternative names and eponyms that were used to identify or describe this dystrophy. So lattice corneal dystrophy type 1, it is autosomal dominant. Again, one of the well-defined dystrophies. Genetic locus is known, and the gene has been identified, and the product is also known. In the case of lattice corneal dystrophy, the onset of the disease is early, as you have with the granular, but these patients tend to become symptomatic a little bit earlier. They may have a marked loss of vision, and they may also have the symptoms of recurrent corneal erosions and a lot of discomfort. And if you see a patient with a corneal dystrophy like this, one should warn them about the recurrent corneal erosions, because often what the patient is not aware of it, when they develop a corneal erosion, they get a foreign body sensation. And the foreign body sensation prompts them to think that there is a foreign body in the eye. And often they may just rub their eyes, or they may splash dirty water in their eyes. And unfortunately, as a result of that, they may land up with an infectious keratitis, which can then just make it into an explosively complicated situation. So you must warn them that you may get recurrent erosions. Keep a bottle of lubricants handy. And if you feel that, start putting the lubricants. If necessary, you may even ask them to start antibiotics and then show the nearest ophthalmologist. May not be possible always to reach a corneal surgeon, but it's good to warn them that you should not self-medicate and you should show an ophthalmologist. Here again, I want to illustrate to you how you can have different variations of the lattice lines. And this is the thing which is so interesting and in a way frustrating. It's not nice to have a disease where there is so much of variation, particularly when you know it's a genetic disease. But that's the way life is, and you can have a lot of variations in the manifestation. And the other important thing is it will also depend when the patient presents to you, because after all, it is an evolving condition. So the patient at the age of 20 will look different from how the patient would look at the age of 30, 40, or 50, because naturally the deposition and the disease progression is an inherent to the disease process per se. So they're refractile lines, lattice lines. They can be visualized in retroillumination. They start centrally, superficially, and then they go centrifugally and deeper. They're generally radially oriented, and they have dichotomous branching, so they can be confused with the nerves. But just remember that the nerves usually will always start from the periphery and taper off towards the center. Initially, the stroma between the lines and dots is clear, but later a ground glass appearance may come. And this is the thing which I wanted to highlight, that both granular and lattice traditionally and typically have a clear intervening stroma. But if you see a person in a very late stage of the disease, or if you see a person who had suffered from infectious keratitis, then these definitions will be blurred. So light microscopy and staining amyloid deposits, very characteristic, and you will see the green birefringence, deposition of amyloid, and it's heavily in the anterior stroma, but it may be there throughout. And again, as I mentioned before, the deposition of the material may not always correspond with the clinical visibility of the lesions. Now, lattice corneal dystrophy type 2 is one of the exceptions to the association with systemic disease. This is autosomal dominant, the gene locus is known and the gene is known. So it is actually felt that it is due to a systemic involvement, and you have very characteristic systemic features such as a facial mask, dermatochalasis, leg ophthalmos. This is not very commonly seen in India. I haven't ever seen a patient who has manifested with this so far, but it is also possible that we may be missing it. So it may not be considered as a true dystrophy if you go by the pure definition. Now, the non-TGF-beta1 dystrophies, stromal dystrophies, are the macular dystrophy, Schneider corneal dystrophy, congenital stromal corneal dystrophy, Fleck corneal dystrophy, posterior amorphous, and the central cloudy dystrophy of Francois. If you see this picture, and if an unexperienced or a person who is not very familiar with the various manifestations of corneal dystrophy sees this patient on slit lamp, you actually see that the most characteristic feature is that you see these discrete deposits. So it actually can be mistaken for a granular dystrophy. But if you look very carefully, there is a distinct haze as compared to the previous slides which I showed you. So there are these lesions which look as if they are granular deposits, but in between stroma is very hazy. And in more advanced cases, this haziness of the stroma will go limbus to limbus. And if you see on a slit lamp, you will often get variations where there are similar discoid deposits at the pre-Descemet's level. And those are the patients who are likely to have a perforation if you go for a DALK. So it is an indication that the Descemet's and the endothelium is also involved. This is also coming as a distinct type of dystrophy, category 1. The exception to this is that this is autosomal recessive. The granular dystrophy, lattice dystrophy, largely the dystrophies are autosomal dominant. This one is autosomal recessive. And being autosomal recessive, the manifestations are obviously more severe. The patients will present at a younger age with more severe drop in vision, and they're more likely to undergo keratoplasty relatively a decade or so earlier compared to the other two. And the product is glycosaminoglycans. So corneal dystrophy, the defective gene, and there is a mutated THST6, and there's a final processing of keratan sulfate, which is impaired, and then we have the deposition of glycosaminoglycans. There can be different immunotypes based on the reactivity of serum and corneal tissue to the keratan sulfate, type 1, type 1A, and type 2. And it will depend upon whether the antigenic keratan sulfate is present or whether it is dermatan sulfate. This is what I wanted to show, that again, if you look very cursorily, you do see these granular-like deposits, but the intervening stroma also shows a ground glass haze, and often extends up to the limbus and the deep stroma down to the Descemet's membrane. And the other thing, if one is confused, is a very distinct, and it is a very useful clinical association, that the cornea is much thinner than normal. So if you have a patient with this kind of appearance and the corneal thickness is less than 500 microns, it may be 480, 470 microns, that goes in favor of a macular corneal dystrophy. Now, this again is an unusual feature, because here you have a disease where there is an actual deposition of material in the stroma, but still it is associated with a relative thinning. And the symptoms, severe visual impairment, can occur much earlier, between 10 and 30 years of age. And we've had patients who required surgery in their early 20s, and the corneal sensitivity is reduced. They can also have photophobia and painful recurrent corneal erosions, but it is rare. It is more common in lattice dystrophy comparatively. On light microscopy, there may be breaks in the Bowman layer. The glycosaminoglycans will be seen diffusely accumulated. Now, if you compare with the others, you can see how extensively they are distributed intracellularly and extracellularly throughout the corneal stroma. And the Descemet's membrane and endothelium are not distinctly involved in terms of the deposition commonly, but it can happen. And on transmission electron microscopy, the keratocytes and the endothelial cells stain positively. So if you see clinically, sometimes there will be deposits pre-Descemet's level. And if you see on the electron microscopy, you will find that the endothelium is actually involved. So this is what I meant when I explained that macular dystrophy does affect the stroma and the endothelium, whereas earlier it was felt that it was predominantly a stromal dystrophy. And the other thing is the endothelium is involved in terms of the deposition, but it is not involved in the terms of functioning, because the cornea is actually thin and you do not get endothelial dysfunction in macular corneal dystrophy. So when we say the endothelium is involved, we do not mean that there is a loss of function. It just means that the deposition is there, the lesion is involving the endothelial layer itself. And if you see that clinically, either on ASOCT or on careful slit lamp examination, then that particular patient may not be a very good candidate for a DALK, may be preferable to go for PK, or you be prepared that there is a likelihood of perforation during the DALK and you take care of that eventuality during the surgery. Confocal microscopy will show highly reflective deposits. Here again, I would like to highlight that we will not really use confocal microscopy that much to differentiate. The basic differentiation is a clinical assessment, but yes, it is nice to know the different kinds of deposits and to have the features documented when you do a confocal microscopy. And the stains that would be used to demonstrate the macular the dystrophy in terms of the deposition of glycosaminoglycans is alcin blue colloidal iron metachromatic dyes per iodic acid shift stain, and electron microscopy. Accumulation of MPS would be seen even in the stromal keratocytes, so intra as well as extracellular. And you have this vesicular and granular material involving the endothelium as well. Now, Schneider corneal dystrophy is another kind of dystrophy which is not very common in India. Often one may suspect it. It is diagnosed in the second and third decade. It is associated with hyperlipoproteinemia. Initially, you may get central comma-shaped subepithelial crystals. Later, you can get an arcus lipoides. This is another of the autosomal dominant dystrophies. Also a category 1, the locus is known, the gene is known, the deposit is known, and the histopathology will show up the lesion stained by oil red O. This is how it will look. Polarized microscopy, birefringent crystals will be seen in superficial stroma. And electron microscopy can also differentiate. Fleck corneal dystrophy is another of the category 1 dystrophies. This is congenital. It is often asymptomatic, dandruff-like, very light deposits which are sparsely scattered in the stroma. Again, autosomal dominant. So it will be like, as you may have noticed, a lot of these stromal dystrophies are actually autosomal dominant. The only exception is your macular dystrophy, which is autosomal recessive. The locus is known, the gene is known, and the electron microscopy will show these swollen maculated cells. Posterior amorphous corneal dystrophy, also category 1. This is again onset in third decade, largely because it is asymptomatic and often because there are so many other associated disorders such as ocular surface disease, trachoma, etc. Often these dystrophies are missed and may not be actually picked up clinically. There may be a gray-white sheet-like opacity. There may be an associated corneal flattening, and histopathology and electron microscopy can confirm. Central cloudy dystrophy of Francois is onset in first decade. It looks a bit like a crocodile shagreen. I had shown you what the posterior crocodile shagreen appears like in the corneal degeneration, but there they are largely peripheral. And in the central cloudy dystrophy of Francois, they'll be more central and axially distributed. They're polygonal, gray-like, and they resemble the posterior crocodile shagreen. Now, a little bit of a practical approach. When is surgery indicated? Largely, one will not do surgery for diagnosis. The diagnosis is clinical, and there is not much to be gained by doing a biopsy purely for the sake of diagnosis, because after all, it is the clinical manifestation and the clinical requirement of the patient which is going to drive the surgical intervention. So surgery will be largely the main indication is if there is a drop in vision. Usually if the patient is complaining of recurrent erosions or if the patient is having some glare, usually one will not go for surgery for that level of involvement. However, if there is a distinct drop in vision or it is affecting the patient's quality of life, then one would go in for surgery. Severe glare, photophobia, decreased quality of the vision, depending upon the level of involvement. Now we have an approach of customized corneal component surgery. So depending upon the predominant layer, one would like to do an associated level of keratoplasty. However, I would like to say there is a trend to prefer DALK to an anterior lamellar keratoplasty because you get better quality of vision, because in DALK only there's hardly any stroma left behind. Practically, it is only the desmoids and the endothelium. So naturally, the quality of vision is better. But on the other hand, the downside is that with the DALK, then you have a risk of perforation, and you need to have a backup donor cornea. And so therefore, there is a case for some patients to undergo an anterior lamellar transplant, such as an ALTK. And if the lesions are very superficial, then you have the benefit of doing a sutureless anterior lamellar keratoplasty, which is assisted with fibrin glue, and that can be a big benefit. Phototherapeutic keratectomy is another very useful alternative, surgical alternative. Largely, it may be to treat the recurrent corneal erosions, or if there is a superficial opacity, it will also provide interim relief and an improvement in vision. The depth of the opacity has to be less than 100 microns, and the cornea has to be adequate thick to allow a residual bed of at least 300 microns. And you have to warn the patient that with this, there is going to be a shift in the refraction, and so that is something that they need to be aware of, and it should be avoided if the patient has any ocular surface disease or any problem with wound healing. Complications is, as I mentioned, there will be a hyperopic shift. However, if you have a person with myopia, one of these dystrophies, then you can do a customized approach. So along with the PTK, one would just do a PRK, which takes care of the refractive error as well as the opacity. And of course, there is a possibility of recurrence of the pathology, and that is another thing that they need to be aware of. So the advantages of lamellar keratoplasty is it is effectively an extraocular procedure. There are fewer intraoperative and postoperative complications such as expulsive hemorrhage. I'm talking about in comparison to PK. Less chance of keratoctogenesis and glaucoma. Less chance of unlikely event of postoperative endophthalmitis, glaucoma, graft rejection, and less rigid criteria for donor selection, which is a very important thing in our country where there is a shortage of donor tissue. And also one can also use the anterior cap from a person who is undergoing DSEC, and the donor tissue has been used for DSEC, so one can use the anterior lamella for a patient who requires an anterior lamellar keratoplasty. One can do it manually, one can do it automated. Advantages of manual is that it is very cheap, less resource intensive, and you may have irregularity in the central corneal thickness, so you can titrate it during the surgery. Automated, the advantages that you do have a smoother surface, less scarring, so a better contrast and glare acuity and better epithelialization, and it would be microkeratome assisted anterior lamellar keratoplasty. Superficial anterior lamellar keratoplasty, we have already done this, but when we're doing ALTK and with the sutures, one would have to have a depth of the opacity less than 160 microns, and the complications could be microkeratome associated. Very rarely there may be an irregular cut, there may be an incomplete cut, There may be graft displacement, residual corneal pathology. There may be an interface haze, anisometropia, recurrence of the pathology, dry eye, epithelial ingrowth, and sometimes even ectasia. But again, there are the advantages that you can have quick rehabilitation. We can use a donor cornea which may not be suitable, may not have a good endothelial count, and there is always the possibility of doing an optical PK later on when required. So this is an example of a superficial dystrophy, and patient has undergone anterior lamellar keratoplasty, which is sutureless. And here you can see the ASOCT picture, an automated example of an automated lamellar keratoplasty. And then the donor tissue is cut depending upon the thickness. So IOCT will help one to know what is the depth of the opacity, so you can decide. And one can even use a microkeratome to cut the host cornea as well, depending upon the depth and the availability of the appropriate blade. So you cut the host cornea, then you cut the donor cornea for corresponding thickness, and then it can be applied with fibrin glue. This is an example of a superficial anterior lamellar keratoplasty. Hemi-automated anterior lamellar keratoplasty is where you cut the donor tissue with the microkeratome, with the cornea loaded on an artificial anterior chamber, and the host cornea you will dissect manually. This is sometimes required if you are uncertain about the depth to which you will be going. So one would dissect out the host first, decide the depth, and then one would dissect out the donor. And then, of course, there's femtosecond laser-assisted anterior lamellar keratoplasty, which is a wonderful procedure because it gives great precision and great accuracy and excellent vision. There's a perfect fit between the donor and recipient because it is customized, better epithelialization and less astigmatism and more rapid visual recovery. Disadvantage, there could be loss of suction and incomplete flap. Epithelial ingrowth cannot be used in dense scars. That is the biggest thing, that you require a relatively transparent cornea for the femtosecond laser to cut through it and give you a precise cut. And in cases of mild scarring, femtosecond laser energy adjustments will have to be done. And of course, it is very expensive. The benefit of the FALC is that you can customize the shape of the donor recipient bed so that it can fit well, have better wound stability, and then you have the benefit of being able to apply less sutures and even do earlier suture removal. Now, deep anterior lamellar keratoplasty, there's an evolution of the various surgical techniques. Direct open dissection can be done where you will mark out the area to be dissected and then directly open it, and dissection with air, hydrodelamination, closed dissection, where one would use help of an air bubble. And then we have the basic premises that one could use, one would like to separate the Descemet's membrane. So for that, one can use air or even a viscoelastic, and you can use a deep, big bubble, Unver's big bubble technique for dissecting out the deeper stroma and separating the Descemet's membrane. There are different surgical techniques which have been described, and the IOCT will again help to know the depth of dissection. You have an idea what is the extent of the residual bed that you are leaving, or if you're extending very thin to one side, and that can also help. And if you do perforate, it helps you to know where it is, so that you can inject an air bubble and then continue with the dissection from a different area. The complications of DALK intraoperatively, there could be microperforations, in which case one may have to convert to PK. And postoperative complications remain a lot similar to keratoplasty, with the exception that the graft rejection is not such a calamity in DALK, because the host endothelium remains the host endothelium, and it is the endothelial rejection from the donor which is the most devastating and optical PK. But you can have stromal rejection, even though it is more easily reversible and you're less likely to lose the graft. It is important to be aware that it can occur. We can have suture-related complications, microbial keratitis. Sometimes you can have double anterior chamber, particularly if you've left viscoelastic in the host bed, then that may imbibe fluid and then increase in thickness and produce a double anterior chamber and interface scarring. And of course, sometimes you can get intraocular infection, because though it is an extraocular procedure, but one does enter the AC to decompress the AC during the surgery. And if one is unlucky, one may introduce infection into the eye that way. During the dissection, they can sometimes be leading to a Uritz-Zevalier syndrome, so a fixed dilated pupil, and endothelial cell loss may also occur if the anterior chamber is entered. And of course, recurrence of pathology is a possibility in all these cases. This is an example of a DALK, and you can see how there is the donor cornea, there is there is a retained endothelium of the host, and then here we have a double anterior chamber where there is a separation of fluid both here as well as here. So this is when there is a separation in the Duas layer, and there is viscoelastic seeped in between. Penetrating keratoplasty is recommended when the endothelium is involved in cases of macular dystrophy, or if you have full thickness scarring, for example, if the patient had an infectious keratitis, or sometimes intraoperatively if you have to convert from a DALK to a PK. Which is why I would like to emphasize is that if you do not have an in-house eye bank and you're planning a DALK surgery, you must have a backup optical grade cornea, or you request an optical grade cornea for the DALK anyway, because after all, it is an optical keratoplasty after all. Advantages is that it is less surgical expertise, relatively speaking. It's not that penetrating keratoplasty is a very easy surgery, but even for experienced surgeons, DALK is in fact initially quite difficult. So in comparison to that, penetrating keratoplasty requires less surgical expertise, and it is less time consuming. And the disadvantages are many, particularly the higher rejection rate. And here again, I would like to emphasize that it is the endothelial rejection which is more devastating, and also more likely that it is not going to reverse and may lead to a graft failure. So here this example of lattice dystrophy. Here you can see the slit section where you can see that the deposits are actually going right down to the posterior stroma. So this is not a good candidate for an anterior lamellar keratoplasty, but a good candidate for a DALK. And often you will find that in these dystrophies, it is not that difficult to separate the Descemet's membrane, and a big bubble works very well. So this is an example of the case operated. But don't forget that here again, there would be sutures, and there would be suture-related problems, including astigmatism. Then recurrence, granular dystrophy is very prone to recurrence. Here's an example where it has recurred after keratoplasty. Macular dystrophy 5.2%, lattice 48%, so high rate of recurrence, and a clinically significant recurrence versus just a biomicroscopic finding of recurrent disease. So one will largely go by whether the patient's vision is affected. It is dropped down to a level that the patient is not able to undergo or carry out the routine daily activities, and the quality of vision has deteriorated. Similarly, there could be recurrent erosion symptoms, glare and photophobia. All of these can come back. So this is a comparison of the major stromal dystrophies, granular, macular, and lattice. Largely, the macular dystrophy is easy to remember, autosomal recessive, so tends to be more severe. The symptoms will come in the first decade itself. The deposits, as I had mentioned earlier, will actually be present in the first decade in all of them, but you may not pick them up unless you're screening the family, or for some other reason the patient comes for a checkup. As far as the reduction in vision is concerned, macular dystrophy, again, it's much earlier, first or second decade, and lattice is the next, and granular dystrophy is by far relatively milder or less severe in comparison. Recurrent erosions are more frequent with lattice dystrophies, and then the opacities, as I explained, are a little different. In granular dystrophy, they are discrete, sharp borders, and the intervening stroma is clear early. As a person ages, if a person is 80-year-old or plus, you'll often find it sometimes difficult to differentiate. In macular dystrophies, the opacity I showed, you do see some deposits, but if you compare to the pictures I showed you, in the macular dystrophy, though they look like deposits, but they're a little more hazy, they're a little more fuzzy with indistinct margins. There's a hazy intervening stroma, and they do generally extend up to the limbus. And lattice dystrophy, you will see the refractile tiny lines and dots, translucent lines and dots. Even if all of them are not so, if you look very carefully, there will be a few like that. But then again, remember that one can mistake secondary amyloidosis for a lattice dystrophy. So often you will find patients with trachoma where you may mistake it for lattice dystrophy. As I explained, macular dystrophy, the corneal thickness is thin. The stains to be used, Mason's trichome for granular dystrophy, colloidal iron and actin blue for macular dystrophy. These are the commonly used stains in India. Lattice dystrophy, Congo red. And the material is hyaline in granular, amyloid in lattice, and glycosaminoglycans in macular dystrophy. And the main distinguishing feature is the clear limbal zone is granular, extensive haziness, limbus to limbus in macular dystrophy, and the thinning of the cornea, and the lattice lines, which you will see in lattice dystrophy. So to give you an example now, we have this patient who is 25-year-old. She has complained of severe pain, photophobia, and diminution of vision. And you see here, so it is a very classical case. So maybe Aarti would like to say what it could be. Or maybe later on. And this is what you see on retroillumination. So you have dilated pupil. Yes, Aarti.
Lattice dystrophy.
That's right. So this is lattice dystrophy, and this is a very, very characteristic dystrophy, but often it will not be so advanced. It will be very subtle, and you have to use your clinical sense to pick it up and suspect it based on the clinical features. And then, of course, it will be confirmed on histopathology Congo red stain. Now, 40-year-old patient, progressive diminution of vision, and this is the lesion that I've seen. Would you like to describe them, Aarti?
Aarti, Asiba, any one of you?
Or anybody?
Ma'am,
Yeah,
it's a discrete opacity with the intervening clear stroma, so suggestive of a granular dystrophy.
Quite right. So that's right. So it's quite fascinating to see. So often they're not so frequently distributed all over the country, but when you see these dystrophies live and you see the actual patient, it's actually very fascinating. And the interesting thing to me even now is that there's so much of variation in the way they manifest. That and it's not yet been defined. Yes, the gene is known, yes, the deposit is known, but it's not very clear why in some people it will manifest in this way and in others it will be other. There's lots still to learn for these dystrophies. And the deposit in the case of granular dystrophy is hyaline deposition. Okay, this is the granular dystrophy. And now we have a 15-year-old patient with progressive diminution of vision, watering, and photophobia. And this is the lesion that you see. Anybody else beside Aarti and or will Aarti like to say?
It's a macular dystrophy.
Yes. So here again, this is very extensive for a 15-year-old. As you can see, already limbus to limbus involvement is there. If you look very carefully, there is a central thinning of the cornea. But people who are not used to it or not tuned to it may mistake it for granular dystrophy, because if you see, there are certain granular-like deposits, and some of them are quite superficial. So it can be, you can mistake it, but you look at the other features, limbus to limbus involvement, the central thinning, as well as the intervening haziness of the stroma. And if you look very carefully, some of these peripheral lesions, these discoid lesions, if you see on slit lamp, and if you see, you can see them here also, there are very posteriorly discoid, showing that there is an involvement of the desmoids and the endothelium. So effectively, this particular dystrophy predominantly it is stromal, but it's going right from the epithelium up to the endothelium. And because of these lesions on the endothelium, there is a chance that the desmoid membrane will be very fragile and high risk of perforation during a DALK. So it would make sense to go straight away for PK for this particular patient. And this is what the picture will look on histopathology. So this is the case of macular corneal dystrophy. Now, coming to the endothelial dystrophies, the endothelial dystrophies are important basically because they are very debilitating because naturally the corneal endothelium is a very delicate structure and it's required to maintain the normal health, transparency, and thickness. And if the endothelium stops working, not only does the cornea become edematous and the vision hazy, but it also can lead to extremely painful and discomfort, a state of great discomfort to the patient. So therefore, they are very important. So the congenital hereditary endothelial dystrophy onset is generally in the first week to 6 months in terms of when the patient manifests. Actually, it is congenital, but the patients may be detected within the first week to 6 months, and sometimes even later on, because sometimes the parents are not that observant, and also the manifestation also may not be that severe. So there is a corneal clouding, there's a blurred vision, and naturally if the visual axis is not cleared within the first 3 to 6 months of life, then it is associated with nystagmus. There's a diffuse ground glass haze and a marked increase in corneal thickness to the extent that the cornea may actually even be double its normal size or double its normal thickness. But don't forget, a very, very important differential diagnosis of this is not to miss congenital glaucoma, because the prognosis is totally different and the intervention is totally different. A child with congenital glaucoma needs to have immediate surgical intervention, control of the intraocular pressure and surgical intervention, whereas a child who has a CHED is going to require a keratoplasty. So it's very important to be able to differentiate, and it is the corneal diameter and the extent of photophobia which is going, and the lacrimation, which is going to help to differentiate. So congenital hereditary endothelial dystrophy is autosomal recessive. The chromosome is identified in 20p13. The mutation in the SLC4A11 gene, and it regulates the intracellular boron concentration, which has a key role in the growth and terminal differentiation of the neural crest cells, and loss of this function leads to an abnormality of the endothelium. And as I explained earlier, that the CHED1, which was originally considered as autosomal dominant, was considered a dystrophy. Now no longer is considered a dystrophy. And whereas it is CHED2, which is autosomal recessive, which is associated with high nystagmus and presentation is very early in the first week with a significant reduced vision. This is taken as the CHED, true CHED in the newer classification. Just to give you an example of some atypical cases, very, very unusual patient which was detected on genetics as well as on histopathology to be CHED, but the patient actually manifested very late in life in the 40s with this kind of appearance. So there is an endothelial involvement, there is a thickening, there is a diffuse ground glass haze, and associated with a spheroidal degeneration. So such a patient may be mistaken for a macular dystrophy actually, if you look at it, but then you will see that there is a thickening of the cornea, there's an edema of the cornea, whereas in macular dystrophy, you will have the haze, but you do not get a thickening, you have a thinning of the cornea. And histopathology of CHED, there will be thickened descemet membrane, absent endothelium, and corneal edema. But this was a very unusual case which actually presented very late. The other important corneal dystrophy is Fuchs corneal dystrophy. This earlier we used to think is not so common in India, but now we are realizing that actually there are extensive number of cases, and either it was not so common earlier and is becoming more common now, or simply we are getting better at diagnosing it with better examination techniques. Earlier times one was hardly seeing every patient on slit lamp, whereas now that is the norm. So that could be one reason why earlier it was felt that it's not so common, but now we see plenty of cases is diagnosed. The onset is mostly 3rd to 4th decade. The early variant could even benefit as early as in the 1st decade. Generally, females are a little bit more predominant. There may be early morning blurring of vision. This is because overnight, when the eyes are closed, there's less evaporation of the tears, as a result of which there is an increase in the corneal edema. And also, when the eyes are closed, there is less nutrition, less of the large source of oxygen to the cornea is through the aqueous and environmental oxygen. So at night, there is a relative hypoxia. And the corneal endothelium is largely depends on this aerobic metabolism. So as a result, early morning, the endothelial cells are not functioning. There's greater epithelial edema. So you have early morning blurring of vision. And through the course of the day, because of the evaporation as well, or evaporation from the tears, which increase the osmotic transition of fluid from the corneal epithelium to the tears, as well as better oxygenation and better nutrition and better endothelial function. Over the morning and by the afternoon, the vision clears. There will be photophobia, watering, and diminution of vision, and there will be evidence of corneal thickening, and there may be confluent epithelial edema, and you may see Descemet's folds, and you may see this guttate appearance. And if you do a specular microscopy, you will see polymegathism and polymorphism. And these cornea guttata are areas of thickened excrescences from Descemet's membrane, which would be seen. And you can also confirm this by confocal microscopy. So the importance lies that if you're going for cataract surgery, all surgery does involve a certain amount of insult to the endothelium. So if one has missed a Fuchs dystrophy preoperatively, and even if one has done a perfect surgery, one may end up with an endothelial decompensation post-operatively. And the other thing with Fuchs dystrophy is often the Descemet's membrane is loosely attached. So you may even end up with a huge Descemet's tear and a Descemet's detachment after the cataract surgery. So it's very important to assess the patient preoperatively. Look at the endothelium in the zone of specular reflection. A slit lamp is good enough to do that. And if you have a doubt, or you see some guttate changes, you see some cell dropouts on specular reflection, then you can ask for a specular microscopy. On the other hand, of course, if you have a very hard cataract, a very shallow anterior chamber, chronic glaucoma, where anyway you would expect that the endothelium may be compromised, there also would be an indication to do a specular microscopy before cataract surgery. So you can have stromal edema with guttate, and on light microscopy, with the endothelium will show variation in cell size as well as cell shape. Polymegathism means an enlargement of the endothelial cells to take up the gaps, to overcome the gaps, or to compensate for the gaps created by cell loss. And pleomorphism is variations in cell shape. Ideally or largely, the endothelial cells are hexagonal and uniform. However, when there is a cell dropout, then the neighboring cells try to expand to overcome that defect, or to take the place of the cells which have dropped out, and that leads to variation in the cell shape. There may be generalized thinning over the apices of the guttate excrescences, and you will have thicker Descemet's membrane. This is what I was talking about, and the thicker Descemet's membrane may be more prone to detach. And the other thing is, even during keratoplasty, sometimes the thicker Descemet's membrane is more elastic. So though you have refined the cornea, you may think you have gone through and through, but actually the Descemet's membrane may be so elastic and thick that it may actually still be in place. And if you're not careful, you will end up with a double anterior chamber in cases of penetrating keratoplasty as well. On electron microscopy, the normal anterior banded zone will be seen with a thinner or absent posterior non-banded zone. And the most typical finding is abnormal posterior collagenous material in the form of the guttate. Confocal microscopy can show the guttate changes and a loss of hexagonality in cases of Fuchs dystrophy. As far as management is concerned, the surgery is largely the procedure of choice, but it will depend upon the extent of involvement or the level of discomfort that the patient is experiencing. One would, if there is an associated raised intraocular pressure, it should be controlled simply because it is giving a positive force or a positive movement of the aqueous into the cornea because of the normal intraocular pressure itself may not be enough. The endothelial function may not be enough to overcome even the force of the normal intraocular pressure. So therefore, you may consider lowering the intraocular pressure. Hypertonic saline, again, it acts largely on the epithelial edema because it increases the tonicity of the tears and allows an osmotic flow of the fluid from the epithelium into the tears. And here again, I would like to say that if you're giving the patient lubricants, you're giving, say, antibiotics, and then you're giving the hypertonic saline, then that hypertonic saline should be the last drop to be put. So largely, if you're giving hypertonic saline to clear up the vision, avoid giving several other drops. But if you have to, then tell the patient to put the hypertonic saline last so that at least it has few hours to act in order to detergest the epithelium. Surgery, the idea is to restore the function. So one will have to replace the endothelial cells. Earlier, penetrating keratoplasty was the procedure of choice, but now the procedure of choice is selective endothelial replacement, provided that there is no extensive anterior stromal scarring, and of course, no great astigmatism. However, I still feel that the point of astigmatism is not that important. As long as there is no anterior stromal scarring, I would still err in favor of doing endothelial keratoplasty. I would not say err, I would more be inclined in favor of an endothelial keratoplasty, because there are a lot of benefits of endothelial keratoplasty over a penetrating keratoplasty. The most important two factors are that the absence of sutures eliminates the suture-related complications such as loose sutures, infectious keratitis, and suture-related vascularization inducing a corneal endothelial rejection. And the other big advantage is, because you are transplanting less tissue, there's the delivery of less foreign antigen to the host, and therefore the chances of graft rejection as such are much reduced. And of course, symptomatic relief can be provided. So supposing you have a patient who has a poor visual function or poor visual potential, but it is a very painful eye, then one can give symptomatic relief by applying a bandaged contact lens. And if that is not enough, or if it's found that the bandaged contact lens is required to be permanently in, then it may be safer to go for another measure such as PTK with amniotic membrane. Now, coming to posterior polymorphous corneal dystrophy, this onset is in early childhood. Often it is asymptomatic. There is a kind of a localized corneal decompensation which may occur. You have to actually look very carefully. Sometimes patients will be coming with glare or some disturbance in their vision, but the cornea may apparently look quite clear. But if you look very carefully on the slit lamp, there may be these little vesicles which may be there in the center or the paracentral area, which will be impairing the quality of the vision. There may be reduced contrast sensitivity, and there may be glare. There could be geographic opacities, there could be linear opacities, horizontal bands, or a railroad appearance. That is why it is called polymorphous, because there are different types of manifestations, and the lesions are largely posterior. And the specular will show sometimes vesicles. Often it is described that if you look at the cells, they look more like epithelial cells at the level of endothelium. That is a very characteristic feature to diagnose a case of posterior polymorphous corneal dystrophy. Management is largely refraction, but later on, if it is too much of a problem, then one will go for keratoplasty. So it's very extensive to go over the various dystrophies. I wanted to just give you a very basic clinical perspective, and I don't expect everybody to memorize all the dystrophies, and even clinical practice is not required. However, it is extremely important for exams. So therefore, from when you're in your academic stage of your career, you need to know it thoroughly in and out. Whereas in practical concern, you just need to remember the practical aspects, and I will be happy to take any questions.
Thank you so much, ma'am, for such an extensive and a simplified coverage of such a huge topic. We have 2 questions from YouTube, ma'am. I'll take them.
Okay.
The first one is there any correlation between the severity and the age at which the child presents in case of any corneal dystrophy?
Yes, so there is a correlation. The more severe the involvement, the earlier the child will present.
And is there any, does it affect the prognosis also?
To some extent, because if the child presents earlier but the intervention is not taken in time, then the intensity of amblyopia is likely to be more. So therefore, that in that sense, it affects the prognosis. So the nystagmus paper, for example, may have already set in, and then that affects the prognosis. And often, it's a bilateral disease, but we are not able to take care of both eyes at the same time. So, and in fact, sometimes the patients who require penetrating keratoplasty, often a very young child, one would actually advise that one should do, because the child has a whole lifetime ahead. Say a 3-year-old, 4-year-old child getting operated, the cornea has to survive for at least 40, 50, 60 years. And largely in our country, you find that often because of many complications, often the grafts are surviving only 5, 10 or 15 years. So therefore, we are doing a best case scenario kind of a treatment, and it's better to keep the other eye as a backup. But then again, it depends. Some patients with CHED are, they have very obvious CHED, but it is a very light manifestation. They may have a vision of 6/60, 6/36, and are able to carry out all their routine activities. So that is a kind of patient where I would not straight away go to operate, because largely if the patient's vision is enough for them to carry on their schoolwork and you monitor the intraocular pressure, one may be better off leaving the child and keeping a close follow-up to make sure that there is no deterioration.
Okay, ma'am.
And one more thing, for CHED, one can do a DSEC as well. Though it is a very thick cornea, that is a challenge, but provided there is no extensive scarring, one can do DSEC. The only difference is, as opposed to DSEC in a normal case where the cornea will clear up much faster, in CHED it may take sometimes 1 to 2 months for the cornea to clear up.
Yes, ma'am. Even there is another question on CHED, that what are the factors to be kept in mind while deciding the timing for the surgical intervention in these patients?
Quite right. So the single most important factor is the vision. And if the child is very small, the child has been brought to you at birth. At that time, you need to assess clinically. For example, sometimes even a newborn child is brought within 2 to 3 days of age. So at that time, the important thing is to rule out glaucoma, because that is something that can be very difficult to differentiate so early on. So you have to take a reliable measurement of intraocular pressure and see the extent of the opacity. Can you see the anterior chamber or not? And then monitor the child very closely for the next 2 to 3 weeks till the child starts looking at the light. And here again, a very young child, the presence of photophobia goes more in favor of glaucoma and corneal edema due to that. And then depending upon the child's vision, if the child's vision is significantly impaired, one may need to operate on a very young child as well, sometimes even within 6 to 8 weeks of life. Here again, one would not like to operate too early, because the child is going to require multiple examinations under anesthesia. So one will usually encourage the parents to get the child to become more healthy and undergo the surgery when the child is about 2 or 3 months old.
Okay, ma'am. Then we have one from the chat box, that what is the reason for hyperopic shift in penetrating keratoplasty when we are actually flattening the cornea?
So I think he was talking about when I mentioned doing phototherapeutic keratectomy. So therefore, you see, what you're doing is you have, so that is why it gives you a hyperopic shift, you see, because the more curved the cornea is, the more it focuses light. So in fact, this is a treatment for myopia. PRK is a flattening of the cornea to treat myopia. So obviously, if a non-myopic person undergoes a flattening of the cornea, then there is a reduction in the refractive power of the cornea. So the light rays are going to get focused behind the retina, and that gives you a hyperopic shift.
That's all from the live streams, ma'am. Hotsetters, you have any questions to ask? Aarti or Asiba, do you have any questions or any doubts?
No, ma'am. That was a hyperopic shift was my question.
Okay.
Thank you, ma'am.
Yes, ma'am. We are done with the questions. Thank you so much, ma'am.
Thank you so much for the opportunity. I really enjoyed giving the lecture, and I wish you all a very safe time and take care. And I hope you enjoy the rest of the lectures.
Thank you so much, ma'am. It's always a pleasure to hear you. It's always a pleasure. Okay, so the next class is on corneal and conjunctival degeneration. That will be on next Wednesday, that is 21st October by Dr. Tulika Chauhan. So till then, good night. Thank you so much, ma'am. Thank you, everyone.